Thank you very much, Mr. Chairman. Yes, I will talk about the interventional and surgical approaches for acute complicated diverticulitis. We saw in the last years, we saw more and more diverticulitis and its complications. For that reason, this is a topic trend, I think, for debating about the management of complicated diverticulitis. The diagnosis can be done with clinical history, symptoms and signs, physical exam, some laboratory tests, but computerized tomography is the gold standard for the diagnosis and for the staging of the complicated diverticulitis. In this talk, I will stress on abscesses, large abscesses, purulent peritonitis, and feculent peritonitis, classified by Hinchey, the grading system of Hinchey, and it is useful for deciding about the management and treatment of these complications. And during my talk, I will give some information about abscess management and also discuss some techniques about the emergency surgery, laparoscopic lavage versus colon resection, Hartmann procedure versus primary resection anastomosis. If you do primary resection anastomosis, if there is a need for defunctioning ileostomy or not, and at the end, I will give some few slides about the open versus minimally invasive surgery for complicated diverticulitis. The abscess occurs in 15 to 40% of the patients, and the cutoff size to distinguish small and larger abscesses varies between different societies. For example, ESCP and ESCRS accept 3 centimeters as cutoff size. European Association for Endoscopic Surgery and SAGES accept 4 centimeters. And the World Society of Emergency Surgery say that the small abscess is less than 5 centimeters size. It depends on the societies. But if you believe that the abscess is small, the antibiotic use is enough to treat this complication. But if the abscess is larger than 4 or 5 centimeters, we should do percutaneous abscess drainage or do a surgery to treat this complication. This is an abscess here, and this is a little bit larger abscess, and the best way to treat it is to insert a small catheter to drain the abscess. If the technique works well, the patient will not need any emergent surgery to treat this complication. Especially the patient was a little bit older and the abscess drainage is enough in most of the cases. For treatment with antibiotics or in combination with percutaneous abscess drainage is successful in most of the cases, up to 80% of the cases. But after percutaneous abscess drainage, there is a risk of abscess recurrence in 15% of the cases, and we may see some procedure-related complications during the abscess drainage. You may harm some intra-abdominal organs, and if the abscess stay long time, we should adjust or replace the drain for the future days. If the abscess is not treated by drainage or sepsis or recurrent abscess, we should go to the operating theater for the treatment of this complication. At the beginning of the last 10 years, starting from 2015 up to 2017, some papers were published from the Scandinavian countries, and these studies talked about peritoneal lavage, which is the best way to treat stage 3 and some of the stage 4 patients, in stage 3, stage 4 patients. Here, most of them included stage grade 3, grade 3 patients. The first one is Lola arm of ladies trial published in 2015, and the authors included Hinchey 3 cases, and they compared peritoneal lavage versus urgent sigmoid resection, and the primary endpoint was major morbidity at 1 year. As you can see here in the yellow part of the slide, the 30-day morbidity was really very high for lavage procedure, 39%. The reoperation rate was again very high, 39%. And the need for abscess drainage after the surgery, after the procedure, was really high, about 20%. But the mortality rate were comparable for both techniques. And the study was prematurely terminated in the laparoscopic peritoneal lavage group because of these bad results. The next one was Scandip trial, again published in 2015. They compared lavage versus urgent colectomy, and the primary endpoint was morbidity. The secondary endpoints were different than the primary endpoint. The primary endpoint, there was not statistically significant difference, but 30-day reoperation and secondary peritonitis rates were high in the laparoscopic peritoneal lavage group, and these were statistically significant. And at the end, the authors concluded that laparoscopic lavage is not recommended for Hinchey 3 grade complication. But interestingly, years later, in 2021, the Scandip group again published their long-term results, and they conclude that shared decision-making considering both short-term and long-term consequences is encouraged. The first study in 2019, they concluded that this is not a good option, but years later, they say that this could be done in some patients, some of the patients. And the other trial from Scandinavia again compared lavage versus Hartmann procedure at that time. Primary endpoint was 1 year reoperation rate, which was high on Hartmann procedure because you do a new surgery for reversal of the Hartmann, and the need for reoperation was high. This is the natural result of the study. But if you look at the secondary endpoints, short-term morbidity and reoperation rates were comparable, and also morbidity, mortality, quality of life were comparable at 1 year, and the authors conclude that lavage was feasible and safe in the short term. This is the positive study for lavage. What can we conclude about the laparoscopic peritoneal lavage? The two meta-analyses included these 3 trials for the comparison of lavage versus surgery. And the laparoscopic lavage is not a good option for the surgical management of Hinchey 3 diverticulitis. This meta-analysis published in 2017, and also the other one is 2017. Why the surgical management of Hinchey 3 is not could be done by laparoscopic lavage? Because laparoscopic lavage was associated with increased risk of postoperative abscesses and need for percutaneous drainage. Last year, in Annals of Surgery, a national course study from Sweden was published. All the patients operated in Sweden between 2016 and 2018 were compared, and as laparoscopic lavage or resection groups. And in additional surgery is more common in the resection group because if you do a Hartmann procedure, yes, there is a need for Hartmann reversal surgery, but mortality did not differ between the groups. And in Swedish routine care, in our era, laparoscopic peritoneal lavage is feasible and safe for hinge A3 diverticulitis. And the Scandinavian countries, especially Sweden, continue to do peritoneal lavage for complicated diverticulitis. When we look at with some practice guidelines from, for example, from American Society of Colorectal Surgeons guidelines, what they say about laparoscopic lavage, in patients with feculent peritonitis, lavage is not recommended. Colectomy should be performed in this situation, and the recommendation is 1A, which is high for high quality evidence. In patients with purulent peritonitis, not feculent but purulent peritonitis, colectomy is preferred over laparoscopic lavage, again with high quality evidence 1A. That means that in United States, the surgeons are pushed to do resection instead of laparoscopic lavage. In 2020, papers were published, 9 non-randomized studies, 2 randomized controlled trials, 2 meta-analyses, and 6 systematic reviews were studied in one paper. All literature conclude that resection anastomosis was superior to Hartmann procedure in the treatment of hinge A3 and 4 diverticulitis, but adoption of resection primary anastomosis is low overall. We completed laparoscopic lavage compared with resection. Now we are looking to the Hartmann procedure versus primary resection after sigmoid colectomy. And in my practice, I prefer in most of the cases resection and primary anastomosis, but it is not necessarily the procedure of choice for each patient. But we should discuss about the need of Hartmann procedure in the next slides. The risk factors for mortality in emergency surgery are a lot. Corticosteroid use, ASA score more than 3, age more than 8 years, hinge A4, creatinine, high creatinine level, low albumin level, and immunosuppression use are the risk factors for the patient. When you look at the risk, mortality risk with 2 factors is 10%, is really high. With 3 factors, 23. And 4 factors, the risk is 53%. And for that reason, before going to the, deciding which surgery is suitable for the patient, we should look at this criteria for deciding the treatment modality. This is an interesting study, Goodbye Hartmann trial, because the procedure is the most common treatment for complicated diverticulitis since 100 years. And it is the mostly used, mostly done procedure for complicated diverticulitis. Can we left behind this technique and go for resection primary anastomosis in our procedures? We should take into account the patient risk factors, time of the surgery, morning or during night shifts. We should look at the experience of the surgeon and also infrastructure of the institution. If all these risk factors are low and you can go for resection primary anastomosis, it is the procedure of choice. In this study, Goodbye Hartmann trial for left-sided chronic emergencies, they included 1,200 patients from more than 200 centers, and the patients operated with Hartmann procedure, some others with resection and primary anastomosis. And the complications rate is higher in the Hartmann group, and 30-day mortality is higher in Hartmann group of patients. It's around 14%. And resection primary anastomosis should be considered as the gold standard surgery, with Hartmann procedure being an exception. This is the result of Goodbye Hartmann trial, but it is really debatable. Again, when we look at the ASCRS clinical practice guidelines to compare Hartmann versus resection and primary anastomosis, the decision to restore bowel continuity after colon resection should incorporate patient factors, it's very important, intraoperative factors, the situation of peritonitis is low or high, and also the surgeon preference, the surgeon experience also is important for the decision. The decision, the recommendation is moderate quality evidence with 1B, and these factors also gives us some idea about the decision of the procedure. Another question is when you do a laparoscopic or open or robotic surgery and done resection anastomosis, is there any need for diversion or not, to divert or not to divert? In this meta-analysis, 17 studies and more than 500 patients were included in the study, and they compared proximal diversion or not in this group of patients. In a conclusion, primary anastomosis with or without proximal diversion have similar postoperative outcomes. That means that you may omit proximal diversion in this group of patients. There is a new randomized controlled trial which is started to be done in France, and this is a prospective multi-center randomized trial, DIVERTI-2 trial. In this trial, the authors will look at the superiority in Hinchey 3 and 4 disease, resection primary anastomosis with protective stoma control group and without protective stoma experimental group. And the primary endpoint is overall 1-year morbidity. There are a lot of secondary endpoints. And we will have the results, I think, this year or next. And this will give us an important information about diverting stoma in resection and primary anastomosis in complicated diverticulitis. Another question, should we done open surgery or minimally invasive surgery for complicated diverticulitis? This is the American College of Surgeons National Surgical Quality Improvement Program study. And almost 10,000 patients included, and only 17% of the patients underwent minimally invasive colectomy in United States. That means that even in the developed countries, the minimally invasive surgery is not the procedure of choice for complicated diverticulitis. But in the result of this, in the conclusion of this study, the authors conclude that whenever possible, minimally invasive approach should be attempted first in emergent colectomy for diverticulitis. There are some, this is a really very recent paper published in surgical endoscopy. There are really a huge variation for the surgical management of complicated diverticulitis in Europe countries. And this, for stable Hinchey 3 diverticulitis, for example, some group of surgeons prefer Hartmann procedure. The primary resection anastomosis choice is very low, but laparoscopic peritoneal lavage prior to sigmoid resection is a little bit high, and lavage only is around 9%. For stable Hinchey 4 diverticulitis, the Hartmann procedure takes place in the first rank. And unstable hinge diverticulitis, again, the Hartmann procedure is the procedure of choice. This really shows that even in Europe, surgeons may have different surgical procedures of choice for complicated diverticulitis. In summary, abscess greater than 5 centimeters need to be treated by percutaneous drainage or surgery. For hinge 3 for diverticulitis, laparoscopic lavage is not a good option. It's debatable. Perhaps in a very small group of patients we can do lavage. Resection anastomosis is superior to Hartmann procedure, but the adoption of resection is low in our era. Resection plus minus proximal diversion have similar postoperative outcomes, and if you have some courage to do surgery resection and without diversion, it's a good option. And minimally invasive surgery should be attempted first in emergent colectomy, but again, the adoption is very low, and in most of the cases, the surgeons prefer open surgery. Thank you very much again.